sofa signed, like have come into our room waiting. Is it 32?
Yes, yes. People are just entering. Yes,
Yeah,
yes.
yeah. It'll take some time. I know in the past, it's taken the first kind of 5-7 minutes. So we should give maybe the five. I'm just suggesting, and maybe it'll be good to hear from Shruti and Chandra, that we should give 5 minutes, right? I think people sometimes are delayed. So we can start 5 minutes late, but intentionally late.
That's fine. Yeah.
Okay.
Well, you've done your best. We just deal with whoever is there in the room and have a good discussion.
Yeah, exactly. Shruti, does that sound okay?
Yes, sounds great. I'll make an announcement at about 3:02 that we're
Okay.
starting in 3 minutes.
Okay, thanks.
Eileen, for the next 1 hour, I have a call, and Rohit may call you. So for me, for my lunch, I'll have.
समझ जाते हैं डॉन स्पीकिंग किरण हरदा
Hello, everyone. Thanks for joining. We'll wait another 3 to 4 minutes and then we'll start. हम 3 से 4 मिनट में शुरू करेंगे.
ओके अभी एक लड़की हिंदी से बोली 3 से 4 मिनट में हम लोग शुरू करेंगे वहां से
Okay, welcome everyone. On behalf of RTI International and Dasra, we just want to thank you for joining today. Today's webinar is going to be mostly in English with some Hindi segments, but there will be summarized translations in the chat. RTI और दसरा की ओर से आज वेबिनार में शामिल होने के लिए बहुत धन्यवाद। आज का वेबिनार ज्यादातर अंग्रेजी में होगी, कुछ हिंदी भाग के साथ, लेकिन चैट बॉक्स में चर्चा का सारांश अनुवाद किया जाएगा. We have a very relevant topic today, as well as a very packed and exciting speaker lineup. Our hope is to just facilitate an interactive discussion and make sure we hear from all speakers very important perspectives. So we will be very particular on time. Apologies in advance if we interrupt anyone. आज का विषय बहुत प्रासंगिक और महत्वपूर्ण है. आज के कार्यक्रम में बहुत अनुभवी और रोमांचक स्पीकर्स भी हैं. हम एक आकर्षक चर्चा की कोशिश करेंगे और चाहेंगे कि सभी स्पीकर्स के विशेष विचार सुन पाए. इसलिए हम समय का बहुत सावधान रहेंगे और कोई रुकावट के लिए पहले से माफी मांगना चाहेंगे. Before we begin, just a few house rules. Can we go to the house rules slide, please? This is a safe space where all opinions will be respected. ये एक सुरक्षित स्थान है जहां सभी विचारों का सम्मान किया जाएगा. Please keep your mics on mute and do use the chat box to ask any questions. कृपया अपने mic बंद रखें और सवाल chat box में डालें. Finally, if you're having any trouble with Zoom, please join via the live YouTube link, which will be posted in the chat. अगर आप Zoom पे connect नहीं रह पा रहे तो कृपया live stream link पे webinar में जुड़ जाए. Our agenda for today will begin with a series of 4 keynote speakers, followed by a panel discussion and then some Q&A. हम 4 मुख्य भाषण से शुरू करेंगे, जिसके बाद एक panel चर्चा भी होगी. With that, let's begin. As I mentioned, I think we want to capture all perspectives today. And perhaps the most important one is that of the inspiring youth who are actually living the experience of being peer educators. जैसे मैंने कहा, हम आज बहुत स्पीकर से सुनेंगे, पर शायद सबसे महत्वपूर्ण आवाज उस स्पीकर का है जो रोजाना साथिया और peer education का अनुभव जी रहा हो. इसी बात पे प्लीज हमारे पहले स्पीकर निशा कुमारी का स्वागत करें. निशा, क्या आप यहाँ हो? निशा? निशा म्यूट पे हो. निशा?
हेलो मैम.
हाय निशा, कैसी हो?
ठीक हूँ मैम.
तो पहले आज हमसे बात करने के लिए बहुत शुक्रिया और साथिया की भूमिका निभाने के लिए भी शुक्रिया. क्या आप पहले हमें अपना जल्दी से परिचय दे सकते हैं और हमें बता सकते हो कि RKSK यानी कि राष्ट्रीय किशोर स्वास्थ्य कार्यक्रम और सिनी के साथिया प्रोग्राम में शामिल होने का आपका क्या अनुभव हुआ है?
मेरा नाम निशा कुमारी है. मैं झारखंड के सिमडेगा जिले से हूँ और मेरे परिवार में हम लोग कुल 9 सदस्य हैं और मैं फर्स्ट ईयर में हूँ. मेरा कॉलेज का नाम SS+2 हाई स्कूल सिमडेगा है और RKSK के द्वारा अंतर्गत सहिया दीदी के सहयोग से हमारे आंगनबाड़ी केंद्र और कई जगह और भी आंगनबाड़ी केंद्र हैं, उसमें 10 से 19 वर्ष के किशोर किशोरियों को सूची मतलब किशोर किशोरियों का सूची बनाया गया, जिसमें हम सभी को राष्ट्रीय किशोर स्वास्थ्य दिवस में एक बैठक के रूप में बुलाया गया और उसी में RKSK के बारे में बहुत सारी जानकारी मिली और हम किशोर किशोरियों के बीच से ही एक किशोर और एक किशोरी का चयनित हुआ, जिसमें हमारे आंगनबाड़ी से हमको चयनित किया गया और मेरे साथ और एक किशोर को भी साथिया के रूप में चयनित किया. चुनाव होने के 1 सप्ताह बाद हम लोगों को विकास केंद्र में ट्रेनिंग के लिए बुलाया गया. वहाँ जीवन कौशल के बारे में 6 मुद्दों के बारे में वहाँ सिखाया गया और हम लोग बहुत कुछ वहाँ सीखे. और उन कार्यों को हम अपने ग्रुप में, हमारा एक ग्रुप है जिसमें मेरा ग्रुप का नाम है रानी ग्रुप। हम लोग वहाँ 10 से 19 वर्ष के किशोर किशोर का ही एक संगठन है। हम लोग उसमें महीना में 2 दिन ग्रुप मीटिंग करते हैं और उसके बारे में छह मुद्दों के बारे में हम लोग ये करते हैं, डिसीजन लेते हैं। उसके बाद मीटिंग, अगर ये मीटिंग हो गया, 1 महीना का 2 मीटिंग हो गया, तो हम अगले मीटिंग के लिए एनएम दीदी, सैया दीदी के सहयोग से हम लोग फिर से ट्राई करते हैं ताकि और बेहतरीन हो सके। साथ ही पीयर एजुकेटर किशोर किशोरियों में से ही चुने गए किशोर किशोरी ही होते हैं, जो किशोर किशोरी से जुड़े मुद्दों में, जैसे उनके स्वास्थ्य, पोषण और भी कई सारी ऐसी चीज है, उनके बातों में अन्य किशोर किशोरियों का मार्गदर्शन करने में मदद करते हैं। पीयर एजुकेटर बनने से मुझे किशोर स्वास्थ्य के बारे में सीखने और समझने का मौका मिला। किशोर स्वास्थ्य में सही गलत परिस्थितियों को समझने का क्षमता भी मिला और साथ ही किशोर किशोरियों को मदद करने का एक सुनहरा मौका मिला। मेरा हेलो मैम।
हाँ हाँ, थैंक यू निशा। नहीं, आपने बहुत अच्छी बात कही है। तो जैसे आप कह रहे थे कि आप सब साथियां काफी सोच विचार के साथ ये मीटिंग्स प्लान करती है, तो आपके हिसाब से इन साथिया प्रोग्राम्स के दौरान समाज के किशोर किशोरियों को क्या लाभ मिलता है, तो उनका क्या बेनिफिट होता है? निशा, आप म्यूट पे हो।
हेलो।
हाँ हाँ, सुनाई दे रहा है।
हाँ मैम, तो हम जैसे कि जो भी किशोर किशोरी हैं वो खुद से बड़े उम्र से मतलब खुलकर अपने शारीरिक और मानसिक बदलाव के बारे में खुलकर बात नहीं करते हैं, क्योंकि वो उनसे बड़े होते हैं। और हम जैसे भी हम लोग जो साथियां हैं वो हम लोग उसी के उम्र के होते हैं, वो लोग हम लोग से बेझिझक बात कर सकते हैं, खुलकर बात कर सकते हैं और अपने समस्याओं का हल भी ढूंढ सकते हैं और हम भी उनके समस्याओं का हल ढूंढने में मदद करते हैं। वो अपने मानसिक और शारीरिक मतलब बदलाव के बारे में हमसे बात करके उनके दिल को हल्का होता है, उनके दिल के बोझ। उसके बाद हम लोग जो भी किशोर किशोरी की बात सुनकर हमसे जो ऊपर वाले हैं उनके पास पहुंचाने का प्रयास करते हैं ताकि उनको अच्छी शिक्षा मिल सके, उन्हें जानकारी और ज्यादा मिल सके।
नहीं, थैंक यू निशा। और आपने एक बहुत ही आवश्यक बात की है कि किशोर किशोरियों को भी एक भरोसेमंद और सुरक्षित साथी और स्थान की जरूरत है। और आज वेबिनार पे काफी सारे ऐसे लोग हैं जो साथी साथिया के प्रोग्राम्स को बेहतर बनाने की कोशिश कर रहे हैं। तो जाने से पहले क्या आप उनको कोई संदेश या सुझाव देना चाहेंगे?
हाँ मैम, मेरा संदेश यही है कि साथिया लोगों का परीक्षण होता रहे, जिससे हम सभी साथिया और भी बेहतर ढंग से अपने कार्य को कर सके और साथ ही साथिया लोगों को प्रोत्साहन के रूप में कुछ मिलता तो अच्छा रहता, ताकि सभी साथिया अपने कार्यों में रुचि बनाए रखें और अच्छे से काम कर सके। इतना ही बोल के मैं अपनी वाणी को विराम देती हूँ। धन्यवाद।
थैंक यू निशा, आपका बहुत बहुत धन्यवाद। और हम उम्मीद करते हैं कि आज की चर्चा से साथिया प्रोग्राम्स को ज्यादा अधिक ध्यान मिले। थैंक यू। Switching lanes a little bit, I think, from first-hand experiences to what the data is saying, I'd now like to call upon Mariam Siddiqui and Dr. Ishu Kataria, both senior researchers at RTI International, to present to us what they have learned from their dedicated efforts and reviews of peer education programs across India. If anyone does have questions during the presentations, please post them in the chat. But otherwise, Mariam and Ishu, over to you, and we're excited to hear from you.
Thank you, Shruti. Can we move on to our slides, please? Okay, thank you. Next slide, please. So sexual and reproductive health and rights of young people is a really important topic, both with respect to health and development. And with India having the largest share of young people in the world, a focus on this age group is quite imperative. So despite the use of peer education globally, when we look at the evidence of its contribution, so as to what changes it's bringing in young people's knowledge, attitudes, and behaviors, that evidence is quite mixed. Also, what we've seen is that little or no evidence exists on what are the optimal conditions for these peer education programs to be effective, and also whether these peer education programs impact other desirable outcomes, such as creation of safe social spaces, friendship networks, and so on. Next slide, please. Therefore, we undertook this systematic review to basically understand the inputs, processes, outputs, and outcomes of young people's peer education interventions that are undertaken in the Indian context, and also to sort of gain insights on their effectiveness with respect to the knowledge, attitudes, and behaviors pertaining to sexual and reproductive health. We also identified additional research questions, answers to which will be showcased in the upcoming slides. Next slide, please. So from a methodological perspective, we set up an advisory group for conducting this systematic review that helped us define our search terms. We reviewed both published studies as well as gray literature between 2000 to 2016 that included a component of sexual and reproductive health peer education for young people in India. We used various databases as well as connected with various organizations that are working with young people. So finally, we included about 13 publications that aligned with our inclusion criteria for our review. Next slide, please. So on to the findings now. Next slide, please. So in terms of the content, we found that most of the initiatives provided about general reproductive health information. However, this was not defined clearly or consistently across these initiatives. We also saw that peer education expanded beyond sexual and reproductive health during these interventions and included other topics. These were nutrition, livelihoods, substance abuse, and so on. In terms of the delivery of these initiatives, about 11 of the 13 initiatives were delivered as a part of the multi-component intervention programs, and 2 were delivered as standalone interventions. A majority of them were delivered in out-of-school settings, in places that were closer for the young people to reach. So apart from the peer educator, we also observed that there were other cadres of workers who helped in the delivery of these interventions. These included community health workers, Anganwadi workers, Sabla workers, teachers, child developmental officers, and so on. Next slide, please. So when we looked at the coverage of these initiatives, the coverage was assessed based on what number of young people within the target population were actually being reached by these peer educators. And the scale varied because the kind of initiatives that we included also varied. So our numbers usually ranged between 84 to about 48 lakhs. But when we looked at the quality perspective, none of these initiatives reported on quality of either the content or the delivery of the peer education. About 5 of the initiatives talked about some aspect of process monitoring. So for example, one of the initiatives carried out on-site supervision with weekly review meetings, whereas we had 2 initiatives that talked about applying a monitoring mechanism involving multiple stakeholders for effective implementation. So I'll now hand it over to Mariam to talk about rest of the findings as well as the implications of our work.
Thank you, Ishu. So next slide, please.
So now what changes have these initiatives affected in relation to SRH knowledge, attitudes, and behaviors of young people? So about 9 of the 13 initiatives reported changes in SRH knowledge, of which 1 was a standalone initiative and 8 were multi-component. And these initiatives reported on puberty, sexually transmitted diseases, and so on. So as an example, I'll highlight an initiative that was implemented by the Center for Catalyzing Change. So C3 carried out peer education for married couples in Jharkhand, and the initiative reported significant increases in knowledge between baseline and endline surveys in relation to a variety of different topics, such as knowledge of family planning methods, awareness of pregnancy detection kits and their use, awareness of the benefits provided by the government of India in case of institutional delivery, and so on. Similarly, around 4 of the 13 initiatives reported changes in SRH attitudes or beliefs, of which 2 were standalone and 2 were multi-component. Now, these initiatives reported statistically significant positive changes in attitudes among the young people who received the intervention. So, for example, a school-based teenage education program, also known as the STEP initiative, reported that young people reached by peer educators had significant increase in positive attitudes towards consistent condom use and positive beliefs towards people living with HIV. Similarly, 4 of the 13 initiatives reported changes in SRH-related behaviors, of which 1 was a standalone initiative and 3 were multi. And these initiatives, again, reported changes in behavioral outcomes, such as increase in reporting sexual health problems, help seeking from healthcare providers, and visiting adolescent mental health services for SRH. However, we noted that only the standalone peer education initiatives had statistically significant changes in behavioral outcomes among young people in comparison to the multi-component initiative. Also, one of the initiatives, called the Yari Dosti initiative, reported several other behavioral changes than the ones besides the ones that we highlight here on the slide. And these include improvements in communication with one's partner on condom use, on sex and STI. And there were also positive trends on the GEM scale, scores associated with decrease in STI risk behaviors among the young men reached by peer educators.
Sorry, Mariam. Quick
sorry.
thing, sorry. There's a lot of static with your mic, so your voice isn't very clear. Do you think you could speak up or maybe try with the video off?
Sure. You can go to the next slide.
Perfect. Thank you.
So now, to understand the effectiveness of peer education initiatives globally, we place the findings of our India review in perspective. So we conducted a global review of reviews, and we examined the global reviews that were published between the years 2001 and 2014. Our reviews included reports of research studies and evaluations carried out in high, middle, and low-income countries. And we analyzed a total of 10 reviews. These included about 22 initiatives, of which 12 were from high-income countries and 10 from low and middle countries. And the overall findings that emerged were that changes in knowledge, attitudes, and behaviors as a result of standalone peer education initiatives are mixed. So that is, peer education was more effective in improving knowledge and attitudes than in promoting healthier behaviors in some initiatives, but not in others. So these findings are also consistent with the India review we conducted. Next slide, please. So besides SRH, the initiatives in India also reported non-SRH changes, such as gender-based violence, child marriage, livelihoods, among others. And again, there was more of an emphasis on knowledge than changes in attitudes and behavior. Next slide, please. So if we conclude our findings, we note that peer education has been used globally in a variety of ways to address SRH knowledge, attitudes, and behaviors of adolescents and young people. Now, although the quantity and quality of the evidence is limiting, our review has been able to highlight important trends and define a framework for future research. Our review of the Indian peer education initiatives did not directly address the optimal conditions for the success of peer education. Therefore, further research is needed on the optimal conditions for success for peer education to provide solid evidence for designing effective programs in India and across the globe. Also, another pertinent research question emerging from both India and global reviews is whether the fields of global health and human rights are measuring the right thing in relation to peer education. So to date, evaluations and research of peer education have judged its effectiveness primarily on changes in knowledge, attitudes, behaviors, and in some cases, health outcomes. Now, these measurements are valuable. However, it is important to further explore the potential of peer education to contribute to a range of desirable health and rights outcomes, such as young people's awareness of their rights to access information and services, legitimation of dialogue on previously taboo SRH issues, young people's awareness of where and how to seek help and their confidence in doing so, improvement in communication between peers as well as between parents and young, and enhancement of social networks. Therefore, taking the next step forward in programming for adolescents and young people in India and globally will require a dialogue regarding which outcomes peer education programs could reasonably be expected to contribute to and the conditions under which they can be achieved. Next slide, please. So that brings us to the end of our presentation. If you have any queries or any follow-up questions post this webinar, we'd be happy to answer. And thank you.
Thank you. Thank you, Mariam and Ishu, for that very informative and structured presentation. Like Mariam was saying, if there are any questions, please post them in the chat. We will continue to post translations. Now, kind of building on what both of you shared about peer education in the Indian versus global context and ideal conditions for programming. I'd like to call upon Dr. Alka Barua to share with us some of her findings on peer education and as it relates very specifically to the Indian context to India's primary health program for adolescents, which is RKSK, within which peer education is a very key component. Dr. Barua, welcome and over to you.
Thank you, Shruti. Can you hear me clearly?
Yes.
Yeah, may I have the first slide, please? Yeah, so next one, please. So before this presentation draws from the findings of a rapid review as well as monitoring of learning districts. I'll explain what learning districts are. But before we go into it, I would like to introduce a little bit about the RKSK program. It was launched in 2014 to ensure that adolescents 10 to 19 years age are able to realize their full potential by making informed decisions related to health and well-being. The specific objectives were directed at six aspects of health: nutrition, mental, sexual, and reproductive health, improvement in that, prevention of injuries, violence, and substance misuse, and address non-communicable diseases. The strategies in the RKSK program were to increase availability and access to information about health, accessibility and use of quality counseling and health services, and create a safe, supportive, and enabling environment through multi-sectoral convergence. And it also gave the flexibility to have separate strategies for vulnerable adolescents. Across all the program areas, the 7 critical components that were the point of focus were coverage, content, communities, clinics, counseling, communication, and convergence, known as 7 Cs. The approach was facility-based, is for facility-based, school-based, and community-based. Next one. Next slide, please. Yeah. So the findings are not just from rapid program review, but also monitoring visits to learning districts. Now, learning districts are districts where need-based, context-specific package of health services and social interventions are within the mandate of the RKSK are being designed, implemented, and monitored to assess feasibility, acceptability, and effectiveness in terms of specific outcomes. These are 10 districts which have been identified. In the rapid review, we reviewed the planning, implementation, and monitoring, and this was conducted at the national level as well as 4 states identified along with the ministry: Haryana, Maharashtra, Madhya Pradesh, and Uttarakhand. Along with it, we did some rapid review also in Bihar, and this exercise has been ongoing since 2016. Next one, please. So the data sources have been primary and secondary. Primary, we conducted interview with a range of stakeholders, and also had group discussions with frontline workers and peer educators, observed the activities related to peer education, including the training as well as community-based activities. Secondary data was from reports, guidelines, protocols, HMIS, and the data was analyzed across 4 dimensions: governance, implementation, monitoring and evaluation, and linkages. In governance, we looked at human resources, budget, procurement, and management. Implementation was rollout of activities. Monitoring, we looked at data for planning and management of the program, and linkages, we looked at convergence with other departments and organizations. Next one, please. So before we go into what we found, we just to sort of highlight what is the peer education model in the RKSK program. It talks about identifying and recruiting 4 peer educators per ASHA area or a population of 1,000. 1 male and 1 female who are school going, and 1 male and 1 female peer educator who are out of school. And they are supposed to be identified along with the village health, sanitation and nutrition committee by the ASHA. Then the ASHA engages the family members. When the family is on board, then these peer educators are recruited with the help of the VHSNC, and they are trained using the same system which is used for ASHA training. The peer educators are supposed to form groups of 15 to 20, as Nisha talked about it, and then have information sharing with these adolescents, either one-to-one, or educate them through weekly health education sessions on the 6 topics, or motivate them to participate in the quarterly adolescent health day, where information and clinical services both are available. They are also expected to support adolescents and refer them to the clinics in the facilities, or refer them to helpline if they are not able to address their problems. They are supposed to maintain a diary of the work they do and report monthly to the ASHA. The support for peer educators and the mentoring of peer educators is predominantly by ASHA, and every month at the sub-center through the Adolescent Friendly Club by the ANM. The medical officer in charge of the AFHC and the block adolescent health coordinator are supposed to overall supervise the program in their area. Next one, please. So this is what the model was, and what is it that we found? We found that the recruitment and training, the peer educators were selected in consultation with ASHAs, but they were not necessarily representative, in the sense that the out-of-school adolescents were not, peer educators were not available in most of the areas that we visited. Resources were allocated in the PIP for peer education program, and master trainers were trained, and they in turn trained the peer educators, but this was a much delayed activity, and the training was a one-time training. In terms of implementation, we saw that adolescent groups were formed by the peer educators. They did conduct sessions, but these sessions were restricted largely to topics such as nutrition, anemia, and a few of them on menstrual health. Peer educators did refer cases to AFHCs and to adolescent health days, but the clinical services were not available in both places, and nor were the counseling services available, because there were huge number of vacancies in both positions. The peer educators did maintain diary or a register where they noted down the activities they undertook. As far as monitoring is concerned, the structured monitoring system did exist, but the data was largely collected on administrative indicators. How many trainings did take place? How many peer educators attended these trainings? That kind of data. There was also, scope for community feedback, third-party surveys, but none of these data was actively used for strategy revision or taking any corrective actions. Mentoring and ongoing support was one of the weakest links. ASHAs were not competent to support the peer educators in many of the activities they talked about, they carried out. I'll talk about it in the next slide. The ANMs did provide support during the adolescent friendly clubs, but these were not as frequently as was envisaged in the guidelines. And the peer educators who were supposed to go to attend these clubs had no transport allowance. They had to spend their own money to attend this activity. The support mainly came from counselors, but most of the counselors we found were female counselors. There was a dearth of male counselors. Next one, please. So if we look at the strengths and weaknesses of the peer education program, we found that the strength was that frontline workers and the village community representatives were actively engaged and involved in selecting, recruiting the peer educators. The training was on paper at least comprehensive in content. It was carried out fairly well and at the convenience of peer educators, usually on the weekends. But the training was not adequate to build the capacity to handle the broad scope of the 6 areas, particularly the mental health part of it, violence, prevention of injuries. These were areas which they couldn't handle. There was no incentive to peer educators, which is what Nisha also talked about. Without incentive, we found 40 to 50% attrition in the number of trained peer educators. Implementation, peer educators were involved in all the activities they were supposed to carry out. They used audiovisual mediums for health education. Their activities were highly participatory in the adolescent health days. Parents were actively engaged. But if you look at the weaknesses, they were not able to reach the out of school adolescents because there were no peer educators in many places who were out of school. The peer educators hesitated talking about sensitive issues such as sexual and reproductive health. There was no transport allowance for them to travel. So they couldn't even seek support at the AFC where they were supposed to get support from the ANM. Coming to monitoring, they maintained records, they were engaged in reporting, they used digital medium for monitoring, and their supervisors also used digital medium for monitoring. But this data was incomplete, usually inconsistent. The format which is there in the guideline was never used to record the activities they undertook. And it did not reflect the quality of sessions or the quality of inputs they were providing. And there was no formal mechanism for corrective action if a gap was found. Mentoring and support, RKSK staff support was mainly from the counselors and good performance was publicly acknowledged. But it was very clear in all the areas that ASHAs were not competent to mentor for sensitive topic related concerns of peer educators. In most of these districts are also aspirational districts and the ANMs had no time to mentor because they were competing priorities. And without support, particularly the male peer educators found it difficult to respond to some of the adolescent concerns. Next one, please. It was not that there were some innovative practices undertaken, particularly during the COVID-19 period. Also, for instance, to motivate peer educators and address attrition issues in Uttarakhand, the peer educators were encouraged to network with others. The networking with other groups, environmental activism groups was encouraged, facilitated. There were exposure visits. They were given small gifts. In Jharkhand, they were issued appreciation certificates signed by the civil surgeon and district welfare officer, which gave them legitimacy in the eyes of the community. In Bihar, there was a proposal and it was partially implemented to recruit shadow peer educators, 14 to 16 years, to assist and later on take on the activity when the earlier peer educators reached the age of 19 and left the group. For implementation in Uttarakhand, offline mobile-based platform was conceptualized and now it is being used for health education sessions. They used mobile projectors to show films on adolescent health, short clips. And this helped sustain interest of adolescents in the sessions. In Jharkhand, the adolescents monitored body mass index of adolescents who attended AHDs and followed them up in the community and charted the course of their nutritional status. They also use social media and Nehru Yuva Kendra helplines for reaching adolescents. And in Jharkhand, for monitoring, they used a dashboard which allowed live monitoring, sort of dynamic monitoring of the activities which were happening. Next one, please. So what were the implications for future of what were the findings? One is, of course, the recruitment to ensure that a representation of out-of-school adolescents who are fairly vulnerable are sort of is there so that they are reached, and some initiative to ensure retention of trained adolescent peer educators. There is also need for a need-based and more frequent training program for peer educators. And it has to be also age specific for the peer educators to be able to communicate critical messages within their existing socio-cultural milieu. We have a design which talks about reaching adolescents where they are, but we don't talk about reaching adolescents using the modes of communication that they use. We have to use innovative technology-based pathways to reach adolescents and use alternative approaches to ensure that no adolescent is left behind. Mentoring and supportive supervision is absolutely critical, and it has to be provided. There has to be budget allocation to incentivize and compensate peer educators for not only the work they do, but also for to sustain their motivation and to ensure that they don't have to spend from their pocket to do this work. And the monitoring system has to go beyond the kind of indicators it currently has to focus on quality of information shared and outcomes to plan relevant corrective actions in case there are any gaps. Next one, is there another? Next one. No, thank you. So that ends my presentation. Thank you very much.
Great. Thank you, Dr. Barua. And I think the way you broke down peer education models and even spoke about the issues was very relevant. And I'm sure we'll come back to it when we have a little deeper discussion towards the end of this session. But this is actually a great segue to our final keynote speaker for today. So Dr. Monica Arora from the Public Health Foundation of India will speak to us about her findings on critical issues and program components which relate to peer education. So Dr. Arora, welcome. And are you here? Sorry, I can't hear you. You're on mute.
Okay. Yeah.
Yes, great. Thank you. Over to you.
Okay. Thank you so much for giving me this opportunity to present in a very important webinar. And it has been a great experience listening to the earlier speakers. I would primarily like to talk about our experiences in India of implementing peer education in various programs in the school setting and in the community setting. Next slide, please. So just to set the context, though we have had various discussions on what has been some of the earlier work. Can I have the next slide, please? Yeah, thank you. So what I would like to just highlight is that the need for peer education is not new. It has been used earlier in many programs, but something that we have learned is that peer have a role in not only promoting health, but it is also important to engage them because they can also create a risk environment. Particularly when we talk about non-communicable diseases, it is very important that we engage them and ensure that the environment is supportive of behavior change or to keep a positive behavior environment. Next slide, please. Since many of these behaviors get etched during adolescence, it is important that we start intervention among adolescents before these behaviors or risk factors have set in. And these are the various themes that we have worked it in the past, and I'll be presenting evidence from only non-communicable disease risk factors as those are some of our evaluated models. Next slide, please. So even though I'm talking about NCD related research and evaluations, our current research on peer education engagement is also around how they are being involved in COVID programming and in COVID response, as well as we have a project under which we are evaluating peer education under RKSK program, very similar to what Dr. Barua mentioned, but yes, we have a long-term evaluation rather than a rapid review. So we will have some important learnings from there because we are trying to compare across states as well as in school and out of school peer educators as well as adolescents and the like. So this model is a comprehensive model that we have prepared from our experiences and our learnings of evaluation. This comprehensive intervention model shows that if we want to bring in behavior change among adolescents, we have to intervene and address all the risk factors that you see are listed on the left side, from individual risk factors to interpersonal and environmental risk factors. So no one intervention will bring about a behavior change that we so desire among our adolescents, but we need to have a comprehensive approach. And peer influence that you see under interpersonal risk factors can effectively be countered. If you see on the right side are the policy and program interventions. So we have peer and family support programs which have been shown to be effective and useful in bringing about prevention and control of these risky behaviors among adolescents and youth. Next slide. So this model is a well-published model, and this has been shared in the pre-reads as well. We call this an impact model. So talking about the evidence that exists, we have seen that there have been various effectiveness shown in the existing programs. Something that I may want to highlight is, as I said, under comprehensiveness, the interventions have to be multi-component. They have to be theory-based, because any program would fail even if we involve peer educators if the intervention that has been designed is not science-based. So we have to have evidence-based programming. The intervention should be multi-component, and selection of peer leaders is something which we did here in earlier presentations. It's so very important. They have to be representative of the group with whom they are intervening. Their training, their engagement, all of these steps are very important, and I'll present some data. But something that we have learned is their ownership of the health issues is very important. They should not just be engaged only to provide awareness and do community talks or engagement, but peer-led health activism is something we found where they felt they can bring about a change, which is what kept them motivated and sustained in the intervention. Next slide, please. This is our slide. Next slide, please. So one of the interventions was on mobilizing youth for tobacco-related initiatives in India. Project Maitri was a group randomized trial conducted in Delhi and Chennai. It was very scientifically developed intervention as well as evaluation. And this intervention model was actually based on what youth and adolescents told they would want in the intervention. So the whole modeling of the intervention was based on the formative research from the field. This was a school-based intervention. And you would see that under the comprehensive model, we have classroom curriculum, school posters, parent postcards, because the information has to reach the families as well. And the last bit is the peer-led health activism, which actually changed the socio-contextual environment in the schools to make them tobacco-free. So that is where the ownership came up. When students and the peer leaders were involved into developing their school policies, they actually wrote the policies on what a tobacco-free school should be like. And I'm very happy to report that what was written by those children, adolescents in 2004, was actually taken up by the Ministry of Health and Family Welfare in the scale-up exercise. Exactly the written part of the adolescents was taken up by the government and given to CBSE, where it was announced as the comprehensive tobacco-free school guidelines. So what they contributed to it actually became the law of the land, which was a very, very encouraging for them. Also, the selection, as I said, is something we need to be very careful on, because the guidelines we had given for selection was that there have to be leadership skills. And we let the students in the class select their peer leaders. Teachers were not allowed to do the selection, but they voted. And teachers were very surprised to see the ones who were selected as peer leaders were not the academic leaders, but they were mediocres in their academic performance, but they had excellent leadership skills. So that is very important when we are designing a program. Next slide. So in our intervention, we had not only curriculum for teachers. Next slide, yeah. So we also had peer leaders manual, and trainings were given particular importance. There were trainings and booster trainings as well, because for a 2-year intervention, just one training is not enough. So we ensured that there were booster trainings as well. Apart from the programming, there were other activities like health art, which they could contribute to. Their own posters were some things which they really liked, which had their own pictures on it, and also conduction of students' parliament. So their engagement in activism is important, which led to these results that you see. There has been a considerable decline in tobacco use among intervention schools versus control schools. Next slide. Also, we did a process evaluation of Project Maitri, and we realized that peer leaders were an important support, which led to these outcomes. However, the schools which had high proportion of teachers trained had also better implementation of classroom curriculum, but also better outcomes and had better interaction between students and peer leaders. So there is importance of including peer leaders, but having teachers is an additional layer of success. Next slide. Similar methods were used in our nutrition intervention programs. Again, peer leaders were a very important component. They were brought into orientation workshops and worked with the teachers in implementing the program. Next slide. And the results clearly show, again, a change in their reported behaviors. So there was an increase in vegetable consumption from pre-intervention to post-intervention, and there is a decline in all the unhealthy food consumption that we see in these results. So to conclude and to remain in my given time frame, my last slide does reiterate what I have talked about. Next slide, please. So interventions have to be theory-based, multi-component, which engage peer educators. Intervention should be over several years if we are looking at an outcome of behavior change. It has to be peer educators facilitated sessions. These have to be interactive, debates, skits, game-based activities. These have to be interactive and not didactic lectures. Selection, training, supervision, and incentivization of peer facilitators is very important. So certificates and what all we have heard is something which keeps them motivated and going on. Training and booster trainings are important. Ownership of health issues that I talked about, and engagement in peer-led health activism where they feel they are contributing to welfare of the society and their peer group, and they can bring about a change. Thank you.
Thank you. Thank you so much, Monica. Series of presentations and for taking us through such a spectrum of insights and thematic views. This initiative is actually very much aimed at cross-learning, and it's under the 10 to 19 community of practice, which is a platform for partners such as all of you who've joined us today to showcase your work, share your research and findings. So while we're not necessarily a funding platform, what we do try to do is present opportunities to bring all voices and all points of view to the same platform and showcase efforts that drive prioritization of adolescent health and well-being. I think something that we've learned today, which actually sets the tone for our final session, is that peer education is not just a concern of community and adolescent participation, but it is the concern. It requires the implementer, the policymaker, the funder, and of course the government to all come together. I'm therefore very excited to now kick off our panel discussion, which we do hope does a good job of bringing together these perspectives constructively. Joining us on the panel today is Mr. Ravi Shankar Shukla from the National Health Mission in Jharkhand, Anand Sinha from Packard Foundation, Dr. Souvik Pine from the YP Foundation, Tanisha Gupta from Dasra, and our moderator, who I don't think needs any introduction, Dr. Chandra Mauli from the Adolescent Sexual and Reproductive Health and Research Department of the World Health Organization. Chandra, thank you so much for moderating this panel with us today, and over to you. We're looking forward to an engaging discussion.
Thank you very much, Shruti. and good afternoon, everyone. Um, I'd like to begin with thanks to the presenters, Ishu Kartaria, Miriam Siddiqui, Alka Barua, Monica Arora. You did a great job in presenting research findings, programmatic experiences. And my grateful thanks also to the young peer educator who shared her own personal experiences. I'm terribly sorry I've forgotten her name. Could you say what her name was, Shruti?
Nisha.
Nisha.
Yes.
If she's there, our grateful thanks to her. We have a good panel here. And before we go into the panel, I just want to say three things. One, I think everyone, the 80 or so people on this call, are all committed to the health and well-being of adolescents and young people in our families, in our communities, and in the country. The second thing is, I think most of us, at least we in WHO, and I think I speak to many people I know and work with in India, are increasingly seeing that and following the principle of nothing about us without us. So, this has to be adolescents involved. And increasingly what we are saying is it's not just the voice of adolescents, it's also the teeth of adolescents. So, accountability. Adolescents are not just there to provide their opinions, but they're also to play a role in getting things done and holding not only themselves, but others accountable for action. And the last point is that the National Adolescent Health Program, the RKSK program, is an Indian program primarily put in place with Indian money. And so almost exclusively Indian money. So we all wanted to work. We all wanted to contribute to the health and well-being of adolescents and to make the best use of the money that is spent to improve the lives of children and adolescents in our country. So those are, I think, three points that I'm sure we all agree upon. And the whole discussion really is going to be based on that. We want to hear from the panel, but we'll come back to the researchers as we wrap up. So I have only two questions, and I hope very much that this can be a conversation. And I think Shruti and Pooja, during the conversation, if there are important points that come up in the chat, please feel free to intervene, just like you would do in a coffee table discussion. So can I please start with you, Souvik? A quick reaction to what you heard from the three presenters. No long speeches, a quick comment, please. What's the one or two key messages you take away from the presentations?
So thank you, Dr. Chandra, for inviting me.
Chandra, please. So, no designations needed.
Yeah, so I feel like from the first presentation, what Ishu and Mariam did, like I think I agree with this point that the peer education model in itself, in a standalone manner, if it doesn't has a multi-year, multi-pronged strategy, would not be able to bring forth a lot of behavioral change. It focuses more on bringing on attitudes and kind of knowledge increase. So that I agree with. So that's a clear reflection what I feel. I feel working alongside the gatekeepers is also important, and also to connecting the behavior with experience. Like if just having a knowledge or just having knowledge of entitlements is not met with a proper service provision when the person goes. So if the experience doesn't meet with what the knowledge are getting, kind of behavior change also would not happen how we envision it. It needs a lot of time, a multi-pronged approach. Right? That would be one of the top reflections which I would have from that presentation. What Dr. Alka presented, again, it's very clear that though we have a great plan, the implementation is where it fails. And there has been multiple innovative approaches what we have been thinking around, but again, like the basic provisions are not there. The representation of adolescents within the decision making is a major miss, which I guess also didn't come up very clearly in the review as such, that the aspect of adolescents' participation in the adolescent health programming, say, which are even mandated by, say, global guidances like the WHO AHA guidance and all of that. So the adolescents usually are given training, and likewise how there is no quality monitoring of the training given to peer educators within the NGO-led intervention. And similarly, the quality of training given to peer educators in the RKSK program is also missing. So that's also an aspect we need to look into. We need to involve adolescents into this space. Their lived realities would be able to shape the programming to a great extent. So yeah, this would be my very top level reflections.
Thank you, Souvik. Thank you for your comments. Well taken. Can we go to you, please, Tanisha? Quick comments, please. Overall, quick comments on what do you believe, what do you take away? If it's one comment, what would it be?
Thanks, Chandra. I think for me, if I could quickly go on two different comments. The first is I really resonate with where Ishu and Mariam concluded, which is, are we really measuring the right success metrics when we're looking at the success of peer education models in India? And I think it really should, we should try to normalize for the sector, whether researchers, funders, or civil society organizations, that changes in behavior in terms of just normalizing conversation around sexual behavior, their awareness of how to seek help, etc., should be used as intermediate outcomes. We should look at a staggered success model, because achieving that behavior change is definitely going to take many years, as was outlined by the other researchers as well. And hopefully this should be able to, we should be able to create a common language of success through this for all the different players in this collaborative sort of space. And hopefully we won't lose heart or steam midway through a really, really long and arduous process once we have that staggered success laid out for us. The second quick takeaway that I have is that we probably need to dig a little deeper and chat with our peer educators, with the youth, to find solutions for a lot of the problems that we discussed today, right? And I think Monica laid out really well what can happen when you do involve the youth right from the start, and how great the success can be. The adoption at scale has been seen by Hriday. And so I think that's definitely a takeaway. How do we do that second level analysis and involve the voices of the youth when developing solutions to some of the gaps we discussed today?
Thank you, Tanisha. Two very good points building on what Souvik said. And I hope we can come back to this issue of, is it successful only if it succeeds in getting a young man to put on a condom, or a young woman to seek contraceptive services? Are there other measures that we can look at? And, what does it take to do it well? We are very good in India in developing great policies and strategies. How do we translate that into good programs, into good management? And that takes me very well to you, Ravi Shukla. I visited your state several times. I've contributed to the evaluation of the Tarunya project, supported the documentation of the UDAN program, and see that, a small new state with leadership, with management, can do great things. What's your take? What is the one message you take away from the researchers? Over to you, Ravi.
Yeah, very good afternoon. The thing is that the importance of peer educators is really something which we all have come to accept. And the question that stays with us after these presentations is what is going to be the modus operandi, and whether we should aim for a saturation model in terms of having peer educators with respect to every geographical jurisdiction at the smallest level which is possible. Then again, it's not something which is going to be sustained without the support of the community. So important thing would be to have presence of such peer educators at village level or at panchayat level, and then also sensitize all those who are involved in implementation, especially with respect to the government machinery. If you discuss, I will say the three departments which are going to be most important would be health department, education department, and then the social welfare department, because of various adolescent activities which are carried out at Anganwadi centers, which has its presence in almost all the villages. So now we will have to think about mapping of all these infrastructure-wise resources which we have, and also the population or the target area to which they cater upon, and accordingly, like what could be the training material which could be developed first of all for the officials or the representatives of the government who happen to be the residents as well. So they are kind of those stakeholders who are both the beneficiaries as well as who can be used as a kind of master trainers. So that's something which is very important. Then again, devising the training material in local language with some activity-based training material. For example, something which can teach people through activity is always going to be better than teaching someone by way of a lecture or by way of any other speech or any other reading material, I will say. So that's something which is going to be important.
Thank you, Ravi. Thank you. You've answered two things. You said, you know, we've come to, you started off by saying we've come to understand the value of peer education. You've also started talking about, you know, what are the things that need to be in place. And, you know, I in the second round of questions, what I want to ask is, why are they not in place? You know, why are they not already in place? And what do we need to do? And I hope that by the time we finish in 30 minutes, we can come up with a short list of to-dos. But let me go to Anand now. Anand, you've heard the three, you've heard Souvik, Tanisha, and Ravi. What is your take to add to what they have said? Over to you, Anand.
Thank you, Chandra. Thank you. I think they've covered most of the points. Personally, what I'm taking away from this is that I think my engagement with peer education as a model started from a position of skepticism, where we felt that there was very little evidence to support the wide scale, sort of scaling up of peer education as a model per se. Over the years, as we've looked at more and more evidence, and I think these three studies tell us, again, feed into that, is that there are values to be gained from the peer education model. At the same time, I think what it also tells us is that there is the need for more rigorous and more high quality research processes that will sort of give us help us really refine and identify what works, where the attention is needed, depending on what outcomes we want. I think 2 or 3 specific things I'm taking away, as you know, I was listening to these great presentations. One is that don't just measure quantitative and process outcomes, figure out how to measure quality and more complex sort of outcomes, even if they're intermediate outcomes. Think about processes of selection of peer educators, potentially engaging peers or young people themselves, and also think about what's going to motivate them, because just the selection and training is not enough. And of course, the whole question is that, when do you say that, what is enough in terms of training and capacity building? It seems that we are saying something from the 3 different studies that suggests that there are models where there is too little, and there are models where there is probably a lot or sufficient.
Thank you, Anand. So just taking stock, we have just over 20 minutes. What I'd like to do now is to have all 4 of you identify one issue that you believe absolutely needs to be done to improve. We've all agreed, I think, that there's a place for peer education. We've all agreed also that there are both good and bad practices. Now, what I'd like you to do, Souvik, and all of you briefly, please, because I'd like to bring the researchers back at the end. Souvik, if there was one thing that you would do, if you had the power in the country, and I know you have a lot of power, what's the one thing you would do and why to achieve this end?
So I guess I would stress upon like the meaningful youth engagement or the adolescent participation as a major part of it, because while the programming was developed in its implementation or even its functioning, everything like the participation of adolescents or young people would be very crucial. So they can dictate like what kind of needs they have to kind of reach the outcomes, what the system is also expecting, and they can also dictate the system or inform the system in a way how the system should also function to kind of cater to their needs. So I would definitely prioritize adolescent health, adolescent participation in adolescent health programs.
Thank you, Sovik. It doesn't mean that the other points that you and others have raised have gone away. They're taking careful notes. We will have a report, but I'm just trying to pin down a short list. You know what they say, what I was taught in WHO is it's easy to make a list of 50. It's harder to make a list of 5. What we don't want is a laundry list because we know it's not easy to achieve all those things. So you made a very good point. Tanisha, over to you. What's your one thing?
So sorry, I think Shovik stole my one thing, but my second thing would be to relook at the teaching methodology and the pedagogy itself through which we're training both the trainers and the peer educators. I think when we talk about increasing handholding support, or when we talk about creating more interactive training material, as Ravi Shankar ji just said, we also need to look at how are the peers or the peer educators learning from this material. Are they just memorizing what's in the modules and regurgitating it each time there is a monitoring visit, or are they being able to internalize a lot of what is being communicated through RKSK and having open, honest conversations in those forums? And towards that, we need to develop analytical rigor at the level of the ASHA worker, at the level of the ANM, and at the level of the peer educator to be able to see through those problems and respond in a more, mature and reactionary way, rather than just repeating what was mentioned in the RKSK book, I think.
Thank you. Paulo Freire kind of understanding the issues, getting a grasp of them, and able to work with them, because that's what you need to engage communities. Over to you, Ravi. Because you represent the government and because the government is so important, you have 2 points that you can identify. The NGOs have a role to play, but we need the government, and it's great that you're part of this discussion. What would be 2 things that you would do if you had the power?
I will reduce it to one only, taking a cue from your the thing is that our ultimate end, our ultimate objective should be to ensure that our target group is enlightened. They are enlightened and they are empowered in the way that they can take their own decisions. If you ask me, what could be one specific manifestation with respect to this, with respect to our state? Children going to other states, or children stopping their education, working in fields not out of hobby but out of compulsion, children working in the homes of other persons, the children being trafficked. This is something where we both empower them, and at the same time we empower them in a way that they have that kind of enlightened liberty. They can take their decisions and they can follow their own course of action, and wherever they need the kind of support, either directly through the government or with the help of other civil society members, we can provide it to them. We are there for them.
No, I couldn't agree more with you, Ravi. I couldn't agree more with you. I think we need to protect children. We need to protect young adolescents. But as we protect them, we need to build their capacity to make decisions and to act on those decisions, and to be aware that sometimes the presence of their peers, or when they're excited or upset, can affect their decision making and acting on them. I worked for WHO. I worked for WHO for 25 years. I remember sitting across the table with a WHO colleague who told me that she was going through a very difficult phase in her marriage, and she was thinking of getting a divorce. She went to her father to talk to him about this, and her father told her that, you have to do this yourself. And she told her father, I am now 35 years old. I have not made a single decision in my life. Every decision that was important, you made for me. That I should go to this school, that I should study medicine, that I should marry this man, I should do this. And now when I'm in trouble, you're telling me you make your own decision. I can't make this decision. So, you can't make decisions suddenly. Decision-making capacity has to be built. Over to you, Anand. What's the one thing you would call for and get done?
Really hard choice, but in the 10 to 19 band, I think we've moved towards a higher end and not enough towards the lower end. And I think we need to focus on starting earlier and moving towards that younger age group. Because if we're going to really affect change over a longer period of time, let's think more about how we can intervene at a younger age.
Thank you, Anand. All four of you, if I put your comments together, Anand says we need to start early. Tanisha says we need to use teaching methodology which helps engagement. It's not a rote learning. When I studied in India, and I know how rote learning is done to pass exams. Souvik talked about engagement, and I think what I heard from Ravi is a philosophy which places decision making in the hands of children and adolescents. We have another 15 minutes. Can we have, please, Ishu and Mariam, and then Alka, and then Monica? Or why don't we go the other way around? Monica, if there was one thing that you would add to what these people have said, this wonderful panel have said, what would you say? One thing again. Over to you, Monica. Monica, are you there? Can you hear us?
I can hear you, but the host had muted me, so I couldn't unmute.
Please unmute all the researchers, my friends, so that they can speak quickly. Over to you, Monica.
Thank you. I feel all of these points made by the panelists are excellent. And what you brought out, Chandra, is also very important about the decision-making skills. So what skills do peer educators learn and benefit from? I think that's a research area we all at our individual level or in our research work need to take up. What skills they learn and what works, what does not work is something which Mr. Anand also brought up. Also, something for the future is in research again, is to look at rural-urban differences. Even in LMIC context, these two geographies are very different. So we need to understand what skills, what intervention for engaging peer educator works in a rural setting would be very different from the urban setting. Thank you.
Thank you, Monica. Point well taken. Over to you, Alka.
I would also like, in addition to what has been said, 2 points, if I can make those, Chandra. One is, of course, to ensure that the vulnerable groups amongst the adolescents themselves, those who are out of schools, those are of younger age, and those are in remote areas, there are no peer educators selected. They have to be selected and they have to address their concerns. That is one thing. The second thing, which is very critical in terms of ensuring that resources are not spent on something which doesn't end up achieving what it is expected to, is attrition of peer educators. That has to be addressed, because if we implement a program where we have 50% attrition, that is unlikely to lead to the outcomes we expect.
Thank you, Alka. I've had several conversations with you after your visits, after your monitoring, and I know what you've come sometimes is with despair. You know, that there's all these peer educators are supposed to have been trained. There is their names are not there on the books. We don't know whether they've been trained. So clearly, we all talk about in the SDG agenda not to leave people behind. And so those are the groups who are most in need. And that the important resources that are being put should not be wasted, wasted. Over to you, Ishu. Mariam, when you spoke earlier, we couldn't hear you well, so please speak loudly this time. Over to you, Ishu. I think she's still muted, Shruti.
Yeah, so I'm now on mute. So I think in addition to what points have been raised, Chandra, one thing that I would like to bring up is around when we are looking at interventions or when we are planning interventions, there needs to be some sort of consistency in terms of data collection, so that we have a level of quality in terms of ensuring the results that we are getting are reliable to us. And that is something that we had also noticed in our sort of the the review that we had done, that there were challenges with the kind of the way data collection was being done, the quality of the data. So I think if some sort of streamlining is done at that level, I think it's going to be beneficial in the overall context. So that would be my one ask, Chandra.
Yeah. Good quality data for monitoring, good quality data for research, because if you get rubbish in, you get rubbish out in terms of reports. Miriam, do you want to add anything to what Ishu just said?
Sure. So I'll add on. So again, as Ishu highlighted, we noticed that there's dearth of data. A lot of work is being done, but it's not getting documented. And it was a challenge to really reach out to a lot of organizations and ask the question, if they are working in the space of peer education and what they are doing. So I think moving forward, it would be really great if organizations, start at least documenting, what they're doing. And I'm sure there are very good learnings, even if programs are not successful. I'm sure there are learnings there as well that could be built on and one could reflect on and then move forward. So I would definitely call for that as a researcher, that there's a need for more documentation and cross-learning. Yeah.
So it was fascinating listening to you and pulling your threads together. Alka said we need to address vulnerable groups and make sure that resources are well used. So a very strong focus on programming. You and Ishu said, Miriam, that we need good quality data collection, we need documentation, in line very much with your systematic review. And Monica said, in terms of the research she's doing, what are the skills that peer educators need and how can we build them and how can we measure them? So just to conclude, we have another 9 minutes. So I just have one last question, and I don't think everyone can have the time to answer this, which is hopefully the world is moving from the fake news world into real, into data and facts and evidence. It's wonderful to hear the president-elect talk about setting up a COVID-19 committee of experts. It's so refreshing. Now, what can we do? Because sometimes in India too, we make decisions based on whims and on who's in the room. How can we move from that to making sure that research and evaluation evidence inform programming? I'm going to ask Ravi to speak to that because he represents the government here. Then I'm going to ask Tanisha to add to that from an NGO perspective, and Anand as the donor who writes all the checks. How can we make sure that the good quality research done by all of you who have presented, all these are Indian researchers, Indian issues. How can we make sure that they don't just feed into journal papers? We won't let them. And we really are proud of what you're doing, Dasra, to table these issues. But Ravi, what does the Jharkhand government, what can you do to make sure that research feeds into programs? Over to you, sir.
Well, there are two things which are connected here. First is the availability of all the research material and findings along with the recommendations with the government. So that should be the first step. That's only when we can take some initiatives further with respect to them. At the same time, my request would be to identify the problems which we are facing with respect to be it initially in the stage of ERS and then finally to RKSK when we talk about the health department. So the problems could be like, suppose, for example, child marriage, teenage pregnancy, sexual abuse, similar. These are the problems. So once we identify that these are the problems which are particularly important with respect to this particular area, this particular state, then after that we can identify the interventions which we try to suggest with respect to these problems. With the help of some examples, some success stories, so that it appears to be something on which we can put our bet, we can apply these indicators, interventions to the ultimate deliverable. The ultimate deliverable would be obviously to see that these problems are taken care of in the way that a long-term institutional, not an ad hoc arrangement is done. It should not be like there is one dynamic officer he's interested in these things and he can pursue it. So he's giving his interest. So these kind of things are being done in the state. It should be like in terms of developing a system, an institutional approach, maybe by way of some MOUs, by way of identifying the clear roles and responsibilities both of the departments of the state as well as the civil society partners.
Thank you. Thank you, Ravi. Both the points you made are important ones. One is people, researchers, programmers need to bring together research evidence and make that available. And the second thing is research priority setting. What is increasingly happening is that at the state level and at the national level, we need to define the 5 most important research priorities so that, researchers don't come in with outside funding to do research they want to do, but they do research that is needed by the programming and feeds into the programming. And, in more and more governments are taking control of what research is done and who does it, so that the research addresses local realities and needs, builds capacity as the research is done, so that it's not necessarily by, and we're not talking of people coming from outside India. It would also be from outside your state, so that it builds capacity in your state and that it's done well. Tanisha, any quick comments, and then we have to wrap up.
Right. I think one of the main things that, at least from our experience of implementation, we can see is that it would be great if research could help us define what incentives and what growth paths can exist for peer educators today, right? What is the sustainability sort of plan for a program like RKSK? But at the same time, I think I would also like to bring in the fact that very often it's difficult for us to be agile. It's difficult for programs to be able to uptake research when they're midway. And so while programs can be informed at the start, we also need to ensure that budgets are not restrictive in the sense that you can't course correct. And so, if today we were to develop what was the pathway for peer educators to be incentivized, NGOs and governments running RKSK today should be able to quickly switch paths and, course correct.
Thank you, Tanisha. But my discussions with the Ministry of Health people in the last 5 years is they're ready to course correct. They invited WHO to and with UNFPA to carry out the program review because they realized it was not working. And so I think that's what we need to push for. You don't lose face when you do a course correction. Everyone gains by this. Anand, a quick last word, and then I hand over back to Shruti.
Okay, since you say I write the checks, I'm going to act as the donor. I think demand high quality research, really. I think one of the things that we are learning as we are reading and learning more about peer education and research around peer education is that in general, there is more low quality research than high quality research. And if we have low quality research, we are given the wrong messages, we end up doing the wrong things, we end up scaling up, and we end up replicating the things that don't necessarily work because we kept the bar too low. So demand for high quality research. From that myself, I'm taking, one of the things I'm also taking away is that I'm always skeptical now of research that says that there is impact. I want to know more about the research than about the intervention in that case, because I want to know if the research has really been done well. And therefore, wearing the donor's hat, I think it's important for us to invest in high quality research that meets programmatic needs, but also to invest in research capabilities of young people and youth leaders. Because if you want them to be at the table to design programs, you have to give them the tools with which they can design. And research is an important tool to design. So how are we building the capabilities of not just, high-end international universities and research organizations to do this kind of thing, but the people who are actually implementing and shaping these programs themselves.
Thank you, Anand. That again brings me, wraps up this discussion on research very well. Ravi started by saying, we need to have all the available research, high quality research, low quality research together. And I think that's an enormous responsibility. Many of us researchers finish a piece of work and go on to something else. And then we need to say, what are our research priorities for our state? And then goes into what Anand says, once we've identified research priorities, to say, if we do research, let's do good quality research. Good quality research doesn't necessarily mean more money. It doesn't necessarily mean expensive research. You can do good quality research without necessarily spending an enormous amount of money. And lastly, I loved your point, Tanisha. We need the ability to course correct. I mean, too many times we are stuck in proposals and programs which are 3-year cycles. You can't change it because somebody has decided what the logic model is and gone away and thrown away the key, and then everyone is left with whatever was decided. Before I hand over to Shruti, I want to say that COVID-19 or not, adolescents are sexual beings. Lockdowns, disruptions, or whatever happens, adolescents are growing and developing physically, psychologically, and socially. I don't know if how many of you in the room have read Anne Frank's diary, but in the context of the Holocaust, in the context of being stuck in this small room, Anne Frank notes down in her diary the beginnings of awareness and stirrings inside her body and mind. And that's happening to our adolescents. And we have to respond to their needs. We'd be happy to share with you what WHO is doing in that area, but that can be another webinar if Dasra is not fed up with WHO. Over to you, Shriti.
Thank you. Thank you so much, Chandra and the panelists. And I think this has given us so much food for thought, whether it's thinking about convergence in the government, to research and evaluation and its role, to adolescent participation. Before we actually round up, I wanted to call on Shelja, who leads a lot of our work with adolescents, to say a few closing comments. Shelja, are you here?
Yeah. Thanks. Less about any closing comments. Just wanted to thank everybody. This is really for us an opportunity to bring various perspectives on the table. Nisha, आप बहुत travel करके आए हैं ये panel में हमारे साथ जुड़ने के लिए. So thank you so much. I know अभी आपको वापस घर भी जाना है. Ravi Shankar Shukla ji, thank you so much for taking the time out coming. I know you're very busy, and your comments on curriculums, participation, agency, and enlightened liberty, I think you said, is something we definitely resonate and words that we live by. Thank you so much for all the research panelists, participants, just reiterating and saying that this platform of ours at 10 to 19 is not to show only one point of view, but to show the different facets of practice, have a more participative, difficult engagement discussions also if we need to. So I recommend that all of us go and through our email addresses or with each other continue to discuss this debate and kind of push each other, because only then will we collectively come to a better quality of responding to our adolescents' health and well-being. So thank you so much to everybody. I also wanted to really thank the Dasra team. This has been a really special engagement for all of us. We're very happy and privileged to have spoken to all these enlightened researchers. We've been reading your papers since we started the collaborative many years ago. And for us to, in Sakshat Avatar, as they say, to have all of you here, it's been a real privilege also. So thank you so much. Back to you, Shruti.
Thanks. And I think building on Chandra and what Shelja was saying, it's important to keep having these conversations, and we will continue to try to do so. If you like this webinar, if you have feedback and suggestions for us, please write in at 10to19community@dasra.org. And just to continue to engage with this community of learners, and for more events and updates, visit 10to19community.in. Have a great week ahead. Thank you for joining today, and we hope to see you very soon at our next event.